Good morning. So today we're going to talk about it's just pulmonary infections due to coronaviruses, but we're primarily going to talk about COVID. Or probably that's going to be the only thing we're going to talk about. So there are different coronaviruses, so right, and then they're known for a while, but today's focus is going to be on specific type of coronavirus, like which cause disease COVID-19. So that's the goals for today. Talk about a little bit about origin of coronaviruses, like a little bit classification, describe the genesis, talk about the symptoms of pulmonary coronaviruses, learn diagnostic methods for COVID-19, and then review a little bit about the vaccines we have now and the mechanism of action, and review treatment options for COVID-19. So one thing about COVID-19, it's an evolving area, right? So disease became like present only a few years ago, and then things change quickly. So especially at the beginning when we started treating with certain medications, like we knew like just like hydroxychloroquine, we knew like 6 months later or like 1 year later that it's not working. Vaccines also changed. There was a lot of companies like creating the vaccine, and some of them worked well, some of them didn't work so well, some of them had side effects. So then this filtered out to like few options. So coronaviruses, they belong to family of coronaviridae. Uh, it's a single-stranded RNA, positive sense. So positive sense means that once the RNA get into the human cells or any other cell, it can be translated into it can go to the ribosome and get translated into the protein. Okay, you don't need any other enzymes like reverse transcriptase or some other enzymes to make it translatable. So coronaviruses were first identified in 1960s. Uh, there is there are reservoirs in bats and other animals like civet cats, camels, pangolins, and we know that some of other coronaviruses that came from other animals, like MERS, came from camels. Um, some of them are very close to the SARS-CoV-2, which is the cause of COVID-19. Like one of them found in bats, this RATG13 has like 96.2 identity to the positive agent for COVID-19. And then virus in pangolins has a 92.4 similarity. So they're like in nature, okay? There's a reservoirs, and then and then there was another. So I'm not sure this is true. Like it's difficult to prove 100% where it came from, right? Because you're like backtracking. So there was a suggestion by the House representatives in U.S. that concluded that it could have leaked from the lab in the Wuhan, okay, in China. I don't think they gave like 100% proof, but they made some investigation, and then they thought that's one of the possible options. So it's in my mind still like some possibility that was created by in the lab. So this is just you don't have to remember this. The coronaviruses like COVID-19, they are like beta coronaviruses. That's just the genealogic tree of the coronaviruses and different types. Uh, so this is pangolin, okay? Don't eat them. Try not to interact them too much because they may give COVID-19, okay? I mean other coronaviruses. Uh, so there are different coronaviruses. There's a human coronaviruses, like a human coronavirus, like the ones causing common cold. They are common, and we knew about them. Like they were part of the respiratory panel. Like patients get checked in the emergency room if they have like viral infection symptoms. So here are like some of the names. Some of the coronaviruses that cause severe infections or may cause severe infections. Uh, right now, COVID-19 is mostly like is not severe infection, but it was more common at the beginning. So SARS-CoV-2 can cause which is COVID-19, can cause the severe pulmonary infection, uh, and then MERS can MERS can cause a severe infection, and then I think I made a little bit mistake here. So one of them is SARS-CoV, and another one is the virus causing SARS, which was in Hong Kong, like I think 15, 20 years ago. And then there's animal coronaviruses. They infect various species, like pigs, cats, dogs, bats. So what may happen if certain animal infected by two different viruses, and then new viruses with new features may come up potentially. And then it can be potential for zoonotic transmission, which means infection would come from the animal source. So this is the basic structure of coronavirus. There is a spike proteins, which abbreviated as nucleic acid, is inside the cell, and then there is antibodies for that as well. There is a membrane protein, there is envelope proteins, and then there is a RNA, viral genome. You remember it's single-strand RNA. So this is the picture from early days of the COVID-19 because the hydroxychloroquine or chloroquine is still as an option, potential option for the treatment. But the rest is true. So it can get into cell different types. It can go like endosome will be surrounded by the membrane, or you can get directly into the cell cytoplasm. And then you can also see here, pay attention that it uses angiotensin angiotensin uh, inhibited to the as a receptor. ACE2 receptors are the path how it gets into the cell. And ACE2 is the angiotensin converting enzyme, right? So that's abbreviation. That's what it means. It's abundant in the body, so that's why once the virus is circulating, it can get into different spots because of this receptor. So whenever we have interaction with the virus or bacteria, especially which we never seen before, the first uh, the first step of fighting the infection would be innate immune response. Okay, it's the first defense against infections. It's not specific and rapid, so even the body never saw the virus or bacteria before, it still has some options to fight the infection, and it doesn't require prior exposure. So there are different molecular components of this innate immune response, which are cytokines. It's a small proteins that signal and regulate immune response. They can be pro-inflammatory, anti-inflammatory, and have other different effects. There's a complement, which is a group of proteins that enhance the ability of antibodies and phagocytic cells to clear the microbes. Some of the complement molecules, they can create like a holes in the cell membrane of the bacteria or viruses and kill. Interferons also may inhibit viral replication and activate immune cells. So continue about innate immune response. So there is interferon 1 is released upon recognition of virus entry, and then interferon 1 can trigger the release of enzymes, can degrade viruses and produce proteins that block the release of viral particles from infected cells. So the problem with the COVID-19 virus that it can block some of these pathways and then degrade humans mRNA, which encodes interferon 1. This is just like example. I'm sure there are like multiple different mechanisms how this virus and other viruses try to evade the immune response. Again, this is just an example, and then it can cause the release of in excess of pro-inflammatory cytokines such as interleukin 6, and then Some people may develop something called cytokine storm. That's the name when you have excessive inflammation, and the problem becomes not the viremia or viral replication, but the excessive response to the virus. So next step, which works pretty well against this virus, is a humoral immunity. B cells produce neutralizing antibodies, primarily against S protein, which is, remember, like on the surface of the virus. And then some of these lymphocytes will differentiate into memory B cells and will stay kind of dormant in the body. And then if you have another interaction with the virus, they'll start making antibodies. So the problem with the S protein is it keeps changing a little bit. So that's why there are different strains, and then the the all the antibodies may not work very well against new strains if the S protein is different. There is also cell-mediated immunity. It's T helpers, CD4, activate B cells and release cytokines to recruit and activate other immune cells, which would be CD8 cells, which actually come and kill infected cells. And then some of them will remain in the body as a memory cells. So that's why most of the time, if you have previous exposure to the virus, then you already have some degree of immunity. So the stages of this is the stages about the viral infection. This is not very specific to the COVID-19, but that's how the stages go here. So in stage one, it's asymptomatic, right? So somebody gets the virus. There is incubation periods. It's usually 3 to 5 days on average, and up to 7 days. I think at the beginning, the average incubation period with original COVID-19 was around like 6, 7 days, and it became shorter. Not sure why. Because of changes of the virus, but I don't know exactly the mechanism. So, and then when virus has replicated, it starts disseminating, and patients do develop symptoms at that point. And symptoms would be like non-specific, right? So it's going to be just the symptoms of viral infection, which are upper respiratory symptoms like nasal congestion, sneezing, sore throat, cough. Fever will be for most of the patients, but not all of them. If somebody elderly may not induce so much fever. Smell and taste of the melt were like more specific at the beginning of the pandemic, but as the virus changed, it became less frequent. Some people use this even like kind of diagnostic tool. If somebody loses the smell or taste, then it was highly suggesting the COVID. Few people will develop GI symptoms like diarrhea, nausea, abdominal pain, and then a minority of the patients will go to stage 3, which is pretty rare now. It's a severe course with complications like respiratory failure, which is again like a reaction with the excessive inflammation. People may develop ARDS, acute respiratory distress symptoms. They may get other complications like myocardial injury, uh, pulmonary emboli, secondary infections. So what happens in the lungs? Uh, so viral replication will damage the alveoli through replicating in the alveolar epithelium cells. It would disrupt alveolar capillary barrier, and then what would happen then? The fluid would leak inside the alveoli, which would cause the pulmonary edema, ARDS, may cause excessive inflammation, which again will cause consolidation, and then that part of the lung will not be participating in the oxygen exchange. Uh, because of all the above, hypoxia will result. Patients will become more short of breath and end up in the hospital. And then rare patients after the acute phase may develop fibrotic interstitial lung disease (ILD) type picture with a long-term respiratory failure, but that's not very common. So there are risk factors for severe COVID-19. And again, this is becoming less and less common uh, because of the vaccines, and then you're probably less likely to have severe infection if you already recovered from it once. So, but older age is still one of the risk factors, no matter what, because if patients have weak immune defense, more comorbidities. Somehow it was shown that male sex is a risk factor as well, but I don't think it's a big risk factor. And the reason, the explanation is like weak immune system, high frequency underlying diseases like diabetes, pre-existing comorbidities. Like most of the patients who would go into severe COVID-19 would be, in my experience, would have diabetes or would be obese or both. So, and other pre-existing comorbidities would be chronic kidney disease, liver disease, immunosuppression from uh, from medications or from cancer or like from HIV. Pregnancy is a risk factor, and then lack of like resources, like lack of insurance, like people may wait longer to go to the hospital or seek attention. And some lab findings were associated with more severe course of disease as well, like inflammatory markers like C-reactive protein, CRP. Just I'll mention long COVID. There is no clear definition, uh, but because there was so many, and it's not very common, so this individual chance is not high. But because there was like millions of people infected, even like I don't know, like with a 1.5% chance, there was still a lot of people who would have symptoms like lingering for a longer, like 3 months at least. And then pathogenesis is not clear. The multiple mechanisms been implicated, like viral persistence, which is I think not very common. Uh, some problems with the endothelium, hypercoagulability, affecting some gene expression profiles, affecting the microbiota in the GI tract, autoimmunity, and symptoms would be fatigue, dyspnea, muscle pains, anxiety, depression. It's basically non-specific, okay? Um, and treatment would be based on the symptoms. What is the main symptom? The main symptom is just depression. You would try to treat depression, right? So we the topic for the lecture is primarily like lung manifestations and pulmonary COVID-19, but just to mention that there would be a lot of extra pulmonary manifestations, and that would happen because the virus spreads throughout the body to extrapulmonary sites, and then there is ACE2 receptors in multiple organs. That's why a lot of parts of the body may be affected. Um, Another mechanism is a hypercoagulability. It was more common at the beginning to have clots and like DVT and PE from COVID. So we would look for that. We would specifically monitor for that uh, for that complication, and you would track like the dimer and check for the like monitor respiratory status, like swelling in the legs to see if there is any clots. It would also would cause systemic inflammation, uh, and then endothelial dysfunction in other parts of the body also would contribute to the systemic uh, symptoms, extrapulmonary symptoms. So what it can cause, like hypercoagulability may cause thrombosis. So you remember there is a Virchow triad, right? Hypercoagulability and damage, which include hypercoagulability, damage to the wall of the vein, uh, and then it primarily would cause pulmonary embolism and DVT, and then arterial thrombosis would be low, less probability, which is a stroke and MI. So stroke and MI would be arterial. Uh, you would watch the D-dimer to look for this complication. A lot of patients, probably most of the patients with the COVID would have abnormal D-dimer. So you need to interpret in the context, okay? If somebody doesn't have any clinical symptoms of the clot, then you would just watch it. But if when the D-dimer was going very high, like 10 times high above the normal range, for example, we would give higher dose of preventative medications like apixaban, and like higher dose of heparin to prevent the clots. It can cause cardiovascular complications like arrhythmias, atrial fibrillation is one of the common ones. Elevated troponins, which can be asymptomatic, but if you check the labs, troponin would be a little bit higher, which suggests the myocardial injury, may cause stress cardiomyopathy when patients develop like heart failure and the heart get dilated, but that's temporarily and usually recovers. It can give neurological complications like encephalopathy, which is also non-specific. Anybody really sick in the hospital will get encephalopathic, like confused and drowsy, lack of sleep. Um, in some cases, can give stroke, which is the from can be thrombotic, or it can be like local local process in the brain. It can give autoimmune processes like Guillain-Barré, which can give also like one of the type of peripheral neuropathy manifestation. Yeah, GI manifestation will be anorexia, diarrhea, nausea, abdominal pain. In severe cases, can give abnormal liver function tests, cholecystitis, pancreatitis. But if somebody getting the medication, the treatment for the COVID or something else, you need to look like, is it really the disease or it's or the treatment? Sometimes medication can give abnormalities in the labs as well. So making diagnosis of COVID, right? So whom do we test? Uh, so if somebody is symptomatic, especially if they like hospitalized, you need to know if they have coronavirus or not, because you need to isolate these people. You don't want to infection spread throughout the hospital. If somebody has outpatient, so not hospitalized, but has a risk factors for severe disease like obesity, diabetes, older age, and patients who have close contact with immunocompromised individuals. So you don't want to, if somebody in your family, for example, has like immunocompromised, you want to know if you have like COVID or not, so you can isolate yourself and prevent the spread of infection. And then you would check in some asymptomatic individuals as well, like identification if will help to prevent outbreak. For example, in the nursing homes and the rehabs, if somebody has like exposure to the patients with the COVID, you may want to check them frequently, like every like 2-3 days, like for a week or for 10 days to make sure the patient doesn't get infection. So because in rehabs and nursing homes, it's spread very quickly. So these are the main tests we use to diagnose uh, coronavirus. The most accurate is each has its own pros and cons. There is not like the best test or the worst test. So PCR, it's a nucleic acid amplification test. It's a highly sensitive and specific. So even like there's a few viruses, like you do the swab from the throat or from nasal cavity, right? And even few viruses may give positive test because it will catch uh, the pieces of the virus, and then this gene, like RNA, will get amplified, and then the test will be positive. And it may stay positive for weeks after initial infection because even like a residual amount of virus when people even not infected and not infectious anymore, they cannot infect, but they still remain positive. That's why we don't really repeat the test. Uh, then there is antigen testing. The benefit of antigen testing is it's fast. It can be done at home, and then rapid tests, which you can buy on Amazon or at the pharmacists for the COVID-19, they use antigen test. The problem is less sensitive because you don't amplify here. Whatever antigen you swap in the nasal cavity or throat, that's the amount of antigen you're gonna check. Okay, you cannot amplify, you cannot increase the amount. So that's why if somebody is really concerned, people may want to do it like twice, just to decrease the chances that it's not coronavirus. And usually it wouldn't stay long for the long. It would not stay positive for a long time. And then there's a serology when you check antibodies. It can be used to identify prior infection. Uh, if you check antibodies against S protein, it would be the same antibody against if you had a vaccine or you had infection, you will not be able to say the difference. But there are different antibodies which are directed against the different parts of the virus which are not induced by the vaccine. So nucleocapsid is one of the types of these antibodies. So right now it's not so applicable because most people, like probably 99%, had coronavirus at some point. So, but at the beginning, we didn't. Somebody is sick and we don't know if it's really persistent of the virus, is it side effect from the or antibodies like from the vaccine or from disease. So we would check nucleocapsid antibodies. And then what other tests you're going to do when somebody presents with COVID? So you do some imaging. Again, if somebody is just outpatient, like minimal symptoms, you don't have to go through this thing. It's just more like a regular viral infection, which you don't have to jump on the like expensive evaluation. But if somebody hospitalized, sick enough to be hospitalized, then you may consider doing this test. So somebody short of breath and especially require oxygen, you would do chest X-ray. And then most of the time, people may have like normal chest X-ray even when they're short of breath. Uh, this will help to evaluate other pathology. Maybe there's a pneumonia there already, or there's a pulmonary edema. Chest CT is the most sensitive, a little bit more accurate than chest X-ray, but rarely needed. CTA, which is a CT angiography, may be used more frequently if there's a concern about pulmonary emboli, because that's really the best way to know if there is a thrombotic complication as a PE. May check the ultrasound of the legs to evaluate for the DVT as well, especially if it's asymmetric. It's one leg is a normal size, another one is swollen, then it's highly suggestive of the clot. For the patients who confused and have neurological symptoms, may consider doing head CT, MRI. On some patients who especially have comorbidities, like most of these patients, like young people, like 20, 30 years old, would be very rarely in the hospital for this. So the typical population will be like 70, 80 years old patients who already had like 5 different comorbidities. That's why they may need to do echo to see their heart function, to see their valves. And in terms of labs, besides non general labs like CBC, electrolytes, LFTs, you may do D-dimer, which uh, if it, for example, jumps like significantly within the hospital stay and patient gets worse, then you may consider that patient may have like pulmonary emboli, right? Uh, Again, you have to, in the setting of COVID patients, the dimer has to be interpreted like cautiously because most of the people admitted with the COVID to the hospital will have elevated dimer. So that's why it shouldn't be the only. Otherwise you end up doing CT of the chest on every single patient. You have to be like selective. And then CRP also helps to kind of trace the course. If the CRP is going high, that can be concerning. They may add another medications to treat the inflammation. But if CRP is getting better, they should look better. So that's all is encouraging. We do EKG also, again, not specifically for the COVID, uh, but to look for the other comorbidities and look for the complications from the COVID, like arrhythmias, AFib. So we'll talk about the viruses, vaccines against the COVID. So most, I think, we have few available now in the US, and then probably most of them being used is the messenger mRNA vaccine, which are made by Moderna and Pfizer. Live adenovirus was approved at the beginning, but it's not used in US anymore. The benefit was one injection instead of two, but then there was very rare complication with the thrombosis in the cerebral veins. So, and that's why it's not used in US anymore because there is mRNAs are a little bit better option. And then later, uh, adjuvant recombinant protein vaccine done by Novavax company was approved as well. So it's a spike protein basically with another piece of the adjuvant which you introduce to the body. There is no genetic material used. It's not live because some people were concerned about injecting like genetic material in them, and then if they really want, there is another option. So this is the mechanism of action of the vaccine. Again, this is the picture from earlier days because we don't have DNA vaccines. Uh, it's only mRNA vaccine. So on the left side here, you can see the the one which we talked from vector virus, which uh, virus is it's not replicating virus, so it's not gonna spread like it's not gonna like replicate in your body, right? But once injected, uh, the DNA would go into the nucleus, and then it get transcribed into RNA, and then from RNA, the body would make the same cell would make the S protein. It's just different ways of how you make your body to produce S protein, right? So if you inject messenger RNA, you remember it's a positive sense RNA, so it gets into the cell. It can be transcribed into the S protein on the ribosome like almost immediately. So then S protein is presented to antigen presenting cells, which is usually macrophages. So, and then with the MHC complex here, it interacts with the CD cells, the CD with the lymphocytes, T and B lymphocytes. T lymphocytes would be responsible for the cell immunity, and then B cells would start producing antibodies against S protein. Okay, and then S proteins would be neutralizing the virus. So that's how it works. So whom to vaccinate? So official recommendation from CDC is everyone from 6 months of older. So, but the people who would benefit most are people who the elderly with the highest risk of the for the severe COVID, immunocompromised, multiple medical conditions. And if somebody had an infection, it's okay to wait like about 3 months because you need to create some immunity against the virus to clean from your body, right? So that's why you have cell immunity, you have B cells, so there is no rush. So these are the benefits of vaccination. It protects against severe disease and a decreased risk of complications. It it doesn't prevent transmission if somebody gets infected, but there are studies showing that it reduces transmission. It may prevent infection, but this doesn't last long for different things, for different factors. Because if the virus mutates, then you're still going to get infection, and then the immunity against, even if it's the vaccine matches exactly the type of coronavirus you infected, still the efficiency starts subsiding like 30% after 6 months. It's also cost effective because if somebody gets hospitalized, it's the system would spend a lot of money for that. So I think we should mention the side effects of vaccines. Nothing is free. So it's some of them are common. Like a lot of patients will get this mild to moderate adverse effects, which is there may be pain at the site of injection because you inject with a needle, so there may be some pain. People may get fatigue, headache, myalgia, fevers, chills, because you're inducing immune response, right? And then the side effects are usually more pronounced after the second dose because it's given after like 3 4 weeks. So you already have some immunity and introducing the antigen, which is already known to the body, and that creates more side effects. Rarely, because because myocarditis, it's mainly young males. It's in one study, it was 10 to 30 cases per 100,000, which means one case per like 3 to 10,000. Okay, um, so because thrombosis with thrombocytopenia, it's primarily the adenovirus, but others also can do it. It's extremely rare. Yeah, it's adenovirus vaccine. It's related to autoantibodies against platelet factor 4, and it's the same kind of similar mechanism with somebody have heparin injections and make antibodies against the heparin, which activates the platelets, and then you develop thrombocytopenia. So platelets go down, but they go down because all these platelets they get like release and activate. So and rarely it may cause autoimmune side effects like Guillain-Barré. It's primarily with adenovirus vaccines, which we don't use in US anymore. So few words about treatment. So when you think about treatment, you need to think like what is the stage, what is the mechanism of your treatment, like what you would do at the beginning, what you would use a few days later. So here I just showed that the viral replication goes like first days, like I don't know, like 6, 7 days, it goes down, and then inflammatory problems may arise, and then when there is a viral replication, you may use antivirals, which would not be very effective, like 2, 3 weeks after the start of the infection. And then, as a potential, there is antibody treatment, antibody therapy, but it's not used anymore because it's first it's expensive to create, uh, and the second because the virus kept changing. I think the companies had difficulty like catching up with these changes, and then as the virus would change, the previous antibody would be not so effective. But we used these antibodies pretty widely at the beginning. And of course, if there is a inflammatory stage, then you would use medications to decrease inflammation. So, whom to treat? Um, you don't have to treat everybody. If somebody's younger without really comorbidities, no obesity, diabetes, you don't have to jump on the treatment. But somebody who is at high risk of complications, uh, you would treat, which are the people of adults 65 years and older who have moderate to severe immunocompromised conditions like cancer, malignancies, hematologic malignancies, HIV, transplant, chronic steroid use. In adults with the risk factors for severe disease like asthma, stroke, CKD, chronic kidney disease, diabetes, obesity, smoking, and then everybody who is hospitalized specifically for the COVID, you would treat as well. These days, a lot of patients with you'll find COVID in a patient who is in the hospital, but the reason they came to the hospital wouldn't be COVID. They would come with a like headache, they come like with a fracture, like uh, viral gastroenteritis. They come for other reasons, and because the screening was like 100% people would get screened for the viral infection for the COVID when they come to the hospital, then you would just like find them. I think these days most hospitals don't check everybody. You would need to have symptoms to get screened for the COVID. But the first few years, I think first like 3 years, everybody got checked with or without symptoms. So here's the study, two studies about convalescent plasma. So the one on the left did show benefit, and one on the right didn't show benefit. So what do you think was the difference in the studies? Convalescent plasma. So the idea is that you would transfuse the immune cells, so like antibodies, which would fight the infection. Why do you think one of them worked and one of them didn't? That's the question. Yeah, so the one study on the right didn't show. You see, the placebo and convalescent plasma was about the same. And then on the left, we see the cumulative incidence of hospitalization. So there was a difference, statistical difference between control and then the convalescent plasma. No, it's not mutation, no. So you see, there's a like clue. So it's a cumulative incidence of hospitalization. That means plasma was given before they get admitted to the hospital. So it was given first days. First, like you remember, like there is a viremia going on. So if you, the idea of the convalescent plasma is or like antibodies is to try, is basically to give the like antibodies against the virus. So it's antiviral treatment. So, but on the right study, they were giving plasma to the patients already hospitalized. So with this, that means they would come. It wouldn't be first few days because for the patients to get complications, get severe COVID, and to get presented to the hospital and get hospitalized, the average time would be like 4, 5, 6 days. So they wouldn't come to the hospital day one. So that's why it didn't work. So, but here it was given outpatient. They selected like high risk patients and then they gave it before they developed severe symptoms. So if you look at the previous image, so they were preventing viral replication with the convalescent plasma. And if you give it too late, then it's too late to do it. So it's not going to work. Um, so in general, convalescent plasma was used again, like broadly at the beginning when options were limited, but it's not very commonly used now. I don't think it's ever used now because we have other options like medications. So we'll talk about antivirals, which we use like these days. So Paxlovid is probably the most common. The the first part of the medication is actually the active medication near nirmatrelvir, and ritonavir is just decreases the inhibits some other proteins in the liver which would metabolize nirmatrelvir. Okay, so but active is the first piece. So it's a protease inhibitor, and it should be initiated within the first 5 days. The earlier you do antiviral medication, the earlier the better effect it's going to be. So it interacts unfortunately with multiple medications. So you cannot remember all of them, but every time you try to order, the pharmacy will run the list of patients' current medications. Some of them you may hold for a few days. Like for example, it interacts with the cholesterol medications like statins, and then it's okay to hold statin for 5 days. It's not a big deal. It's a long-term medication. So then you would hold the statin and then take Paxlovid for 5 days and resume. So in early days, it was shown to be really very effective when a lot of people were not vaccinated even yet. It decreased the risk of hospitalization 89%. Okay, I don't think right now the benefit could be less because if somebody had the virus before, they already have some immunity, or if somebody was vaccinated, so the benefit I think was shown to be like decreasing after time. Not because the medication changed, the virus changed, but because patient already have some immunity. So molnupiravir is the second choice. It's a nucleoside analog, which means it's the virus. The virus captures this medication and then try to build the RNA, and then it blocks the build of this RNA because you cannot you cannot build the next nucleotide on it. It can be used as an alternative to Paxlovid when it's contraindicated, but it's overall like less effective than Paxlovid. And then another medication we start using pretty early is remdesivir. They did studies outpatient. Like the problem is IV. You cannot just give it to anybody. You have to put IV line. You have to give it. So, but when it's given early, it showed very good results. Like 80-90% chance decrease in the hospitalization if you give it early. But it's not very common. It's not used now outpatient because it's complicated to give IV medication, especially if it's like twice a day. When somebody hospitalized, then it's for the COVID, then it's common to use. And as I mentioned, monoclonal antibodies they're not currently used because the virus keep changing, and then it became like not cost effective, not profitable to make these antibodies and then pursue these mutations. So if minority of the patient, few patients would go into the second step, like the third step, which is inflammatory. So the virus came to the body, replicated, it caused some damage, it caused inflammation. Now your body overreacted, and now you need to decrease its inflammation, which is the body's reaction becomes the primary problem rather than the virus itself. So, and then here's the main option. So you may use glucocorticoids, which is dexamethasone. So there was a study showed like if somebody requiring oxygen, and then you give them steroids, and then that would decrease the mortality and hospitalizations in those patients. Later, other medications to decrease inflammation were introduced. One of them is the baricitinib, is a JAK2 inhibitor. JAK is a Janus kinase gene, so an inhibitors like a enzyme, and the inhibitors would decrease the decrease inflammation basically. It's used for severe disease on high flow oxygen or mechanical ventilation. Uh, and then tocilizumab is another medication which was known from before. It's used like in the rheumatologic diseases like rheumatoid arthritis. It decreases the interleukin 6 pathway, and that's how it decreases the inflammation. So I think that's it. So, any questions? Uh-huh. Uh-huh. So I think what they did, a lot of information, a lot of like research was already done from before. So especially when there was a SARS in Hong Kong, I think it's 2000s. So people, like I mean, research labs, they knew that there is this virus, and then I think there was some work done from before. So uh, and the second, everything was just like accelerated, right? So if you want to develop like vaccine against, I don't know, like cholera, right, or like some malaria, which is kind of in a stable state, and it's not like spreading like crazy. So that's why financing was different also. So there was they put a lot of funding into the testing. Uh, that's why it was done so quick. The but the methods how to inject mRNA and then create like immunity, the mechanism was already there. So it was just like applied. I don't think you would be able to create the whole path of the using mRNA and vaccine that quickly. But because again the methods of the problem was like you had to create the stable like suspension, right? So with messenger RNA to surround it with the with the lipid. So and then messenger RNA it also has to be like changed a little bit. So right, so you have to have specific like primer there so that ribosome would recognize it. So those things, a lot of them were already kind of developed, but they were not developed specifically for the coronavirus. So when coronavirus came, they just like applied the previous methods. And also, the virus was abundant, right? So if you try to like create a vaccine against like some rare disease, like you have to enroll the patients, it takes time. How much time is going to take like to enroll? Like if you have like one case a week, but when you have like million cases a week, then enrollment goes quick. So that's why the publications about the like on the primates, like on the monkeys, they started coming like just basically a few months later. So because the the method, the technology was already there, and they were showing like I think the in 2020, like 6 7 months after the start of pandemic, there were already articles like in New England Journal of Medicine showing like if you inject this vaccine, I think it was Pfizer or Moderna, then they would uh, create the antibodies in apes or like monkeys, and then they would try to infect the monkeys with coronavirus, and then they would get infected. So this was already like I think around July, like 5 6 7 months after the start of the pandemic. So I think that's what happened. Hmm? Yeah, yeah. No, I think did I mention type 1 or type 2? Okay. I think I put pneumocytes. I'm not sure I mentioned. I don't remember. It's type 1 or type 2. Okay. Hmm. I don't remember. I don't know. Uh, yeah, I don't remember exactly. It was a type 1 or type 2. So I guess it's going to affect the like a lot of cells, right? So if it's type 2, maybe it's an error. Maybe it's an error. So it's going to affect like the most abundant alveoli, alveolar cells. Just if it's type 1, then it should be type 1. It probably could be an error. I mean, you never know 100%. Like, but I think in general, I think it exists in the nature, right? So and there's a high chance it may jump, especially if there's a lot of interactions. Like million people get like exposed to animals. But again, there is no 100% proof that it was made in the lab. It's just like this is just like kind of the how the process works with this House of Representatives. They just created all the evidence they could access to, but Chinese wouldn't give like all their records, right? So and there was some. It's kind of the interviewing all the people and then researching this investigation, and the conclusion was that it's possible that it leaked from the lab. So, which is again like because there was a few outbreaks with severe coronavirus infections, like especially SARS in Hong Kong, like the mortality was high. Like I think mortality was like 30-50%. So people were concerned that if this virus comes back, then you may have a problem. So they were able to catch it early, but if they don't, then and it spreads throughout the world, then it will be really a problem. That's why I'm sure somebody was like researching, investigating the virus, but I doubt, although even if it's legal, I doubt they were doing like bioweapon or something. Like I think you just like do research on the viruses. So and you have to follow like precautions like for the high risk lab. But again, like it's not possible for us to say for sure. Uh-huh. So thrombocytopenia alone would be unusual to kill. Uh, Most of the time, they would die when they died, like early days, with the respiratory failure. Respiratory failure. So they would develop ARDS, so they require more oxygen. But in spite of all the treatments, steroid, baricitinib, tocilizumab, trying to decrease the inflammation wouldn't stop. So then they become hypoxic, uh, and then some of the people will end up on the breathing machine on it. So it also was some lack of knowledge at the beginning. The idea was like if you intubate these patients earlier, you would do they would do better. But then I don't think that was the case. So once those patients get intubated, like early days, they had in the best case like 50% chance of surviving. So later we started managing them without intubation as much as we can. So you would give first normal nasal cannula, and then there's oxygen setting called high flow. So it's a bigger tube. It's a high concentration of oxygen, but it's also kind of blowing the air. So it helps somewhat to ventilate your lungs, even without like ventilator. So that would allow to treat hypoxia a little bit more effectively. So then you would use this setting, and you would use intubation only when all this fails and the oxygen saturation is like consistently like in 80s, like or low 80s. Then intubation still would be used, but then they wouldn't get extubated like next day because the problem would resolve. So they would stay intubated like sometimes for a week or 2 weeks. So even like you intubate like healthy person for 2 weeks, like patients like healthy person, right, cannot walk after that because like your muscles atrophy, you're losing like 1 pound of muscle a day. You got the condition, and then because it's all a lot of like elderly people, then they would develop other complications like the pressure ulcers. They would develop like uh, bacterial infections on top of that. So something would cause like kidney problem, like medication or contrast or dehydration or the virus. But most of the time they would die from hypoxia respiratory failure. So very rarely it can be caused by the PE, like clots. But usually you would recognize them early, and then if it happens at the hospital, you would recognize that because it's usually sudden worsening. But a lot of people, I think, would die also like from PE at home before they come to the hospital. So I think the hospitals reacted differently. So the one I work, like it, I think they were prepared pretty well. So started in December 2019. In 2020, in February, we already had a meeting saying like this is the coming. So the eventually it's going to reach. So and it did reach the hospital. So what was done, um, all the non-urgent stuff was kind of put on hold, like screening colonoscopy, right? Even like some elective like joint changes. So like some of the floors were like reorganized just specifically for the COVID. A lot of doctors involved in treatment of other conditions like uh like like GI people like anesthesia. There is no like elective surgeries. They would work in ICU just to manage the patients, like COVID patients. So so the basically with like the flaws of like just the COVID, uh, and then the because there were so many sick patients. Like normally, if somebody requires like certain amount of oxygen, would need to go to like step down or ICU. So the rules were changed also a little bit that if you're hypoxic but you're like awake, we would give you this amount of oxygen on the regular floor. Just watch because there is no other place for you to go. So the rules were a little bit like adjusted. Um, yeah, otherwise it's again, I know some other hospitals in other states, they were like more chaotic. There was no like staff. There was no like some personal protection equipment. So a lot of people get sick. So, but where I worked, I think it was pretty well like organized and like stepwise. So, and then another thing was also we didn't know how to treat it, right? So at the beginning, we would give chloroquine, like other medications, and we would meet with the infectious disease and look at the research studies. So interesting part was like there was no like established treatment, so it was all like evolving. So one week you treat one medication, and then 1 month later, like it's all something else. Or you would be intubating these patients, and then 3 months later, you say, "Oh no, you don't intubate. Like we just give oxygen." So from the medical, like as a from professional standpoint, that was also interesting that the the procedures would change so quickly. So, and there was a committee in the hospital with infectious disease and other specialists that would make the would adjust the guidelines sometimes like every week. So there was like a link on the website, like you go like this is the current guidelines for the COVID in our hospital, and that would be changing literally like every week. So so that was interesting time. Okay, thank you, thank you.